Hello, everybody, and welcome to the 30th installment. We're at 30. Oh my goodness, we've been doing this 4 years now. 30th installment of the PhenoTips Speaker Series. I'm your host, Kira Deneen, and today we were talking about the role of genetic counselors in genomic mainstreaming. So I think this is a very interesting topic, and we've got three experts that I'm very excited to be able to pick their brains. So thank you, everybody who is rolling in live. I see the numbers just going up and up and up. So just to give everybody a bit of an outline of what we're chatting about today, again, we're going to be talking about the role of genetic counselors in genomic mainstreaming. I'm going to be interviewing our three amazing experts, but I also want to make sure we answer the questions that you have. I think especially with this topic, a lot of us are going to be thinking about different ways that GCs are in this position to be able to help with this. So any questions you guys have, if you are listening to this live, you can use the Q&A box and pop your question in there. If you use the chat, I might miss it. So please use the Q&A box and I'll try to remind you guys to be able to do that as well. And as many of you know, PhenoTips is the sponsor for this speaker series. And PhenoTips has created this complete EHR or electronic health record integrated solution for medical genetics. So this is software and services that reflect the diversity of modern families and ease genetic counselors' workflow. It is built for the future of genomic medicine. So aka very, very timely in terms of what we're talking about today of mainstreaming. We need better genomic health records because the ones that we have now, electronic health records, they're not built for genetics. We've all, at different points, experienced the pains of how that doesn't work. So that's why PhenoTips created their genomic health record. And it includes tools like inclusive pedigree builders, automated pedigrees based on basically a survey from patients, and human phenotype ontology capture. It even has this built-in cancer risk assessment, diagnostic insight. So it's really helpful, not just for one of these aspects, for all. And they created this because they're like, hey, this is a need. We need that unified, seamless genetic workflow. As I mentioned, I'm Kira Deneen. My pronouns are she, her. I am the host for this webinar. And I also host a couple other things. My main gig is DNA Today. It's a genetic podcast. If you enjoy this conversation, you will very much enjoy DNA Today because it's basically similar conversations. Laura Hersher, one of our guests here, has been a guest many times. Whenever something is happening legislative wise that affects us in genetics, Laura is my first email. I'm like, hey, when are we recording? So you can check out lots of episodes. We've got over 300 on there. And then one of my other hats is a prenatal genetic counselor. So I also work in the clinic in the US, kind of the New York, Connecticut line there. But enough about me. Our focus is on our three experts today. And I would love for you three to introduce yourselves because some people listen to this as a podcast. And so it's helpful for them to identify who is talking when. So Laura, I've already picked on you and you were my mentor through grad school. So you're always an easy person to pick on. Laura, do you want to introduce yourself? And then we'll toss it over to Dimitra and then Jill.
Sure, I'm happy to, Kira. Hi, I'm Laura Hersher. My official title is Director of Student Research at the Joan H. Marks Graduate Program in Human Genetics at Sarah Lawrence College, which is quite a mouthful. But I'm a faculty member at the Sarah Lawrence Grad Program, but I do research, but I also am the faculty person in charge of ethical, legal, social issues course, which I've been teaching for about 20 years. And really outside of Sarah Lawrence, that's where my role has been in the field. I am a writer. I've written for a number of publications, writing a lot for Scientific American lately, and done a little bit of podcasting, but not in competition with my student who has far exceeded me as a podcaster. So is that enough? So it's just sort of the Elsie beat, really.
Yes, and I want to just publicly congratulate you for the Natalie Weisberger Paul National Achievement Awards that you were presented with at NSGC in New Orleans this year. So, really, really big. I think probably one of the biggest awards in genetic counseling. So congrats, Laura. That's just simply amazing. But I'm also not surprised because you very much earned that as being very much a public figure in genetic counseling. Dimitra, would you like to introduce yourself?
Yeah, it's very hard after this one. Well, I'll try. Well done, Laura. My name is Dimitra. I am a genetic counselor. I have practiced as a genetic counselor for maybe 10, 12 years, and I've specialized in cancer genetics. And I also had my time in cardiac genetics and interestingly worked within mainstream settings. So I have seen that side of things as well. After that, I got into transformation. So I now am a genomic transformation manager, and I've done a couple courses on service design. So I'm trying to understand how to best design something that would work not only for the patient but also for the clinician, and that would flow well. And most recently, I have accepted a role as chair of the British Society for Genetic Medicine. So that's me. Thank you for having me.
Yeah. Congratulations. No, you're like such a perfect person to be on talking about mainstreaming genetic counseling and how
Thank
genetic
you.
counselors can mainstream genetics. Jill, you also have been a trailblazer in cancer. Am I getting that right?
So yeah, I've been hanging around a while. So I'm Jill Stoffer. My pronouns are she, her. And I have been working in the cancer genetics space since 1994. I was part of the initiation of the cancer genetics program at UPenn. And we were back in the research days then, where a lot of what we did was under a completely different framework. And then over the years, I moved to Dana-Farber, where I am the associate director of genetic counseling there. Dana-Farber is a cancer center. It's all cancer all the time. And we have seen over the years the increased need to provide genetic information to our patients because increasingly it guides care. And so I've worked on a number of initiatives over the years to try to come up with alternative models to get access for more patients and it, while still delivering excellent care. And so we have a very interesting model, I think, at Dana-Farber now that is kind of an integrated model where it's not pure mainstreaming, but it still accelerates access. And very excited to be here having these conversations today.
Yes, thank you so much. Yeah, the three of you, my goodness, I have a lot of insight to tap into in the next hour. And as a reminder for people, I am an interviewer. I always have a million questions, but I want to make sure we get to your questions. So please make sure to use that Q&A box at the bottom if you are listening to this live on Zoom. So I figure we should start with our conversation of actually defining mainstreaming, just so that we're all on the same page in terms of what those goals are, in terms of how we are mainstreaming genomics, because I think genetic counselors are uniquely positioned to be able to have a really, really powerful role, maybe more than any other person, healthcare provider, genetics expert. Does anyone kind of want to start out the conversation of how you think of mainstreaming and just defining how that should or could look in healthcare? I know,
Well, I can
tough.
take
Who's
it.
going to start? Yes,
I can
Jill,
take
thank
a
you.
stab. So I think the perception of mainstreaming is that it really circumvents the traditional model. The traditional model being that in order for genetic assessment and genetic testing to occur, you meet first with a trained genetics professional for pre-test counseling. Then there is a determination of whether genetic testing should happen, what genetic testing should be offered. And then once results are available, there is a post-test genetic counseling session in which those results are reviewed and then next steps are determined. So that's kind of the classic model. And I think when people think about mainstreaming, it really can take different forms. I think in its purest form, when people think about mainstreaming, it kind of does away with a lot of the pre-test counseling at the very least, where those who are providing direct care for patients regardless of the space, if it's in neurology, if it's in the prenatal setting, if it's in the cancer setting, those who are providing the care directly to the patient for their condition are the ones who are arranging the genetic testing, providing the pre-test education. And I think that's really what we all can agree upon is mainstreaming. But then, there are some programs that will select certain results, so positive results identifying pathogenic variants for return by a genetics expert. There are other programs that provide mainstreaming where all results are provided by the same team that's caring for the patient in the absence of a genetics provider, and then a referral may happen. And so I think, the common thread in mainstreaming is that there is really the acceleration of access by eliminating the requirement for pre-test genetic counseling by a genetics professional.
Yeah, because there's just simply not enough genetic counselors, I think, for as more and more people are getting genetic testing, and that in general is a great thing, and being able to have all that information. But for genetic counselors to do all the pre-test counseling, I think it's just not feasible with the direction that we're going in terms of having that goal of genomics being mainstreamed. And I think within this too, there was an interesting, and I'm not going to remember what episode it was, Laura, but there was something on The Beagle Has Landed, the podcast that you do, that you host and interview a lot of genetic experts, where you were talking about, and I want to say it was when I was a student, so this is 4 or 5 years ago, that you were talking about how we're in this spot where a lot of genetic counselors have a specialty, right? I'm a prenatal genetic counselor. That's what I do. Do I know about other areas? Yes. But if we're talking about what I'm an expert in, don't ask me about cancer. Don't ask me about peds. I don't know. But where are we going to come full circle where genetic counselors are no longer going to be like, this is really my specialty? And we're going to have to go back to our roots that we do everything, kind of how it was where genetic counseling started, that you didn't have specialties. First of all, am I getting your viewpoint right from 4 or 5 years ago? Second, do you still have that viewpoint?
Kira, I don't remember what I had for breakfast yesterday.
I know you did. That's why I phrased it that way. But I was like, it really obviously stuck with me.
I was really glad. I do have thoughts about that. I was really glad that Jill took that question, because I feel like, as someone who's been, like, cancer is sort of the model in a sense. It's the place where we've seen this happen first, right? And we went from a model which was really, it was really just almost like a research, like a research study, even when it was clinical in the early days. So everyone could be seen by a genetic counselor, because we treated it as like, let's see how this is working. You know, it was a very small trickle of people that we were seeing and so on. To 2013, the widespread access of panel testing, which happened rather suddenly, and a big expansion of who was able to get cancer susceptibility testing, and like, what effect did that have? And I remember, I'm sure Jill is really the person to talk to this, but like, I remember some of the oncologists in those early days saying like, oh, yeah, I don't want any of those other genes on I don't want any of that information, because they couldn't explain it. So either they were referring to genetics, or they were uncomfortable getting the extra information, right? I mean, like, there was a period, and then things that are routine become routine. I feel like I'm speaking when Jill should be speaking. Like, do you agree with this sort of trajectory? That
Yeah, I mean, I think that, my personal prediction of the future is that genomic medicine affects so many different disciplines and can be used proactively to plan healthcare over a lifespan, that I see it being practiced in primary care routinely. And
you're getting to predicting the future, which is what we're supposed to do here, but I like predicting the past because it's much more reliable. So it just, right, exactly. So what I'm saying is, coming out of the time when genetic testing in cancer is really, it is mainstream. It is mainstream. It is a part of the way medicine is used now.
Well, it's mainstream in that, right? It's baked in. It's baked into practice.
Yes.
Absolutely, yes.
And so this is to Kira's question. So I'm saying, what does the genetic counselor do? Well, what falls to the genetic counselor then is to handle the things that aren't routine, that are complex, and that are beyond the silos, right? Because the oncologist is never going to be comfortable doing what Jill just said, using the genetic information that goes outside of the silos. So yeah, I would stand by that, which I think is that as we see these various disciplines, as we see genetics become routine within these various disciplines, it will fall more and more at us to be the generalists, to be able to talk about, what meaning does this have outside of the silo? Or what about this that is atypical? I don't know.
Mitra, I feel like you have
I
something to say here.
Yeah, I agree and disagree. So I think there's a few points where you're right. We would become the generalist that would see the complex cases that either present with an unusual family history or a VUS or a condition that is very complicated or perhaps has an unusual presentation. But I also think that in the past, let's say 10 years ago, 20 years ago, we're testing, let's say, a very small proportion of the population. And hence, we had a very small number of patients to see. But I wonder, if we're talking about the future, in 5 years' time, 10 years' time, when perhaps we will be testing every single individual diagnosed with a specific cancer, we will end up with a large number of individuals who have a positive result. And if we were to also deem our role as the ones that look after those patients and families who have a confirmed diagnosis, because at least in the UK, the way that I see it is that perhaps the colorectal nurse can offer a genetic test for someone who may have Lynch. Once that individual has a confirmed diagnosis, it could be up to a genetic counselor to offer them their long-term planning, management, surveillance when it comes to gynecological issues or family planning, etc. So I think that there could be a need for specialized genetic counselors within cancer or prenatal, just because we're seeing vast numbers. But at the same time, we would need to have generalists that would explain unusual presentations or family histories, as we mentioned before.
And that's my concern, because and it might differ in the UK versus the US, maybe it's the same, but are non-genetic health care providers, so these nurses, doctors, NPs, you name it, are they trained enough in genetics to be able to offer the right genetic testing to patients, right? Like Jill talked about, especially 20 years ago when we first had BRCA testing available, and even, before the Supreme Court case, it was really, really expensive, all that. There were a lot of changes. It took so long for oncologists to be comfortable enough to order BRCA 1 and 2, let alone then adapt to the panels. Do they know enough to even order the right tests? Because me in prenatal, I all the time am like, all right, this is what was ordered. This is the carrier screening. They got 3 conditions done. And then I'm having to explain, all right, you had the 3 most common conditions done for carrier screening, but would you like a bigger panel with hundreds of conditions, right? So I'm often, see if I get in trouble for this, but correcting what the original provider ordered, right? And trying to not step on their toes. So I think that's a big issue, at least that I can speak of in the US. Dimitra, would you say that that's similar in the UK? And Jill and Laura, you can chime in after too, in terms of if I'm getting that right, because that's my little experience in prenatal.
Yes, we do get that wrong, but I feel like it actually is a systems problem instead of a training problem.
Mm-hmm.
And that's purely based on the fact that our field evolves so rapidly that even for a person who is trained in genomics, tomorrow you'll wake up and there'll be another panel, or the panel will have other genes, or there'll be so many new things even for us. So we need daily update, let alone our colleagues who work in different disciplines and have a different focus. So I think it shouldn't be on the person to know every single thing about every single gene and every single panel. It should be about to the system to point to the right test. For example, if I have a hematology test or a very basic biochemistry test, if one of my markers is outside what is deemed normal, it'll be highlighted red. And on the report, something would say, consider for X or Y. Or if, for example, my sugar levels are higher, then my doctor would say, oh, you need to do this or
it
something
gives
else.
them the next step. It gives the provider like the next
Exactly.
step.
I think we don't have that in genetics and we need it.
Yeah. And I don't mean to put the blame on non-genetic healthcare providers. It's just the frustration of me being a clinic genetic counselor of seeing that happening. And it's not their fault, right? It's not like there are things that they're not doing that they should be. It seems to be, it's a systematic issue of how do we have people trained. I have a cousin that's in med school, and every time he does come home for the holidays, I'm like, so how much genetics are you learning? And it's the books I give him, that he's like, oh God, Kira's giving me another genetics book to read. But, I do get nervous about that I think we need to update that, but that only lasts for so long, right? I graduated 4 years ago from Sarah Lawrence, and it's already at the point where a lot of what I learned in terms of what testing I'm ordering for patients is quite different. Some is the same, but a lot is different. So keeping up with the training, that am I kind of getting that right, Demetra, of like what you're saying of just how are we keeping people updated?
Yeah. Or how we help everyone be updated, including us as well.
Yeah. Right. Yeah. I think that's an important part. Jill. Yeah.
So, when I predict that a lot of genomic testing will happen in primary care, that's the start. This is not a process where you have one encounter with a genetics provider and now we're done. It's all been wrapped up with a bow. I think a lot of screening testing will start in primary care. I think a lot of specialty testing will start in wherever the patient is being treated, whether it's in a neurology, pediatric, or oncology setting, it will start there. And that's kind of, again, the mainstreaming approach. But I don't see how genetic counselors can be the masters of everything, every condition, given how vast our information access is now, how much we need to be specialized in these different areas of practice. And so, if genomic screening becomes more routine, for example, and then someone has a finding of significance, one of the roles of someone who has vast expertise in genetics and genetic counseling is to figure out what are the opportunities for this person now going forward. Are there prevention opportunities? Are there screening opportunities? Are there research participation opportunities? And then helping them identify those resources. And that's certainly something in the wheelhouse of genetic counselors to figure out, what to do next, but to understand, the basis of what testing did I have? What are the limitations of the testing that I had? But then the follow-up for people who have these diagnoses, I think it's like anything in medicine. There's the generalist who can be the core traffic controller and really figuring out what is going on here and helping people get into the right place. And then they're going to be the specialists who have deep knowledge and have access to specialty care to help that now manage that condition over a lifetime. And I think, that we know there are vast differences in the genetic tests that are offered. And it's really hard to imagine that someone who's not trained in genetics can understand some of the limitations of one assay versus another. And did this assay adequately cover the promoter region and, those sorts of details. And so there's, sort of the screening, public health kind of overarching testing that may become more commonplace in medicine. And then there's the specialty care. And I don't think one is going to replace the other. I think they're both going to be critical components.
Well, I so agree with you, Jill. And so here's my concern, right? I think the part of what you're describing is the part where genetic counselors should always have a role because it takes more than 5 or 10 minutes, right? Like it's what's not going to happen in the context of it's sort of a typical medical, whatever specialist encounter, because it takes some time and it takes some explanation, it takes some nuance. And we've heard forever, like the end game of mainstreaming is everybody just has their whole genome sequence there available to be looked at, right? Like that information is available to be tapped into. But it turns out the real sticking point with that is the information is not valuable without someone to explain it and to go into depth and to do that. Not fast, can't be speeded up, not simple process of looking at whether it's, this could happen in a lot of contexts. So Jill just described some really well. And right now I'm very concerned. We've conquered so many of these technological barriers that were there to begin with. Okay, it wasn't cheap, it's cheap enough, it's good enough. I remember in maybe 10 years ago when it's like, well, we would never want to just have that information because it gets better every time you sequence it. The sequencing quality was improving so much. There's less of that conversation now. There's interesting things to say about that, but it's less of an issue, right? That you need to resequence every year because the technology is getting better. But what we absolutely have not figured out is how do we get paid for that time, that human time that you can't cut out of the equation? That's us, right? Like, that's what I'm worried about. Like, I'm not worried that genetics going to make its way into the mainstream in terms of like, the Chat GPT will know something about, what does it mean to have this gene? But to actually be helpful to people requires people time. And I don't see in that getting written out of the question. That I think that it's on them to understand it. I cannot tell you how many conversations over the last decade I have had with or heard people giving talks where they're like, and then whether they're talking about research or studies or clinical, they're like, and then they wave their hands and they're like, genetic counselors. Like the genetic counselors will come and make that happen. And what if people don't understand this? And they're like, genetic counselors. And I feel like I said, like, we're not genetic counseling fairies. We don't just show up like when you wave your hands like that and make this happen. Like there has to be jobs and there has to be funding. And from our point of view, that means we have to have a commitment to showing that not only is this information useful to people, make them their lives, but that the counseling part is useful to their to outcomes, right? We need to do the work to show the relationship between genetic counseling and outcomes in terms of health. So I just think there's some really huge challenges there because you can get it's great. It's great that we have this technology. It's great that we have this PhenoTips technology to get the information into the medical record, to have it there available. But to have it be useful to people is another step. And that's just, we're good now at producing genetic counselors, but we have to create positions for them.
And I think part of that too is getting the Access to Genetic Counselor Service Act passed and put in there. And I think in terms of the US at least, and I think the new genetic counseling CPT code hopefully is also a step in the right direction. We're, 6 weeks away from that being, January 1st, we're starting to use that new code 96041, I believe. Not if I'm getting that right. So I think there are things that are going to help in terms of genetic counselors getting paid for our services, and then that leading more institutions to be like, oh, the ROI on genetic counselors is pretty good, we should hire them. And I think there's going to be a lot of downstream effects to that, because in the US this May, the graduating class, and Laura knows this because, Sarah Lawrence has a new class every year. And Colleen Campbell, the the president of NSGC in New Orleans at the conference, saying, yeah, this was the lowest percentage of graduating genetic counselors that had jobs like at graduation. And it was
across. She was talking across the field.
Across the field. Okay. Yeah. But so, and I think a lot of that goes back to, we need these certain things put into place so that more institutions, organizations, companies are like, oh, we need to hire genetic counselors, because our skills and all of this and what we can do, I think that's already been proven. But it's like, well, where's the finances behind it so that we can do all of this and we can have more of this mainstreaming happening? And there's a lot of questions popping off in the chat, and there's some that I want to get to now. And these are all anonymous. So someone says, there are genetic counselors who work in primary care and a group trying to establish a primary care SIG in NSGC. It is a work in progress to define scope of practice and learn the skill of triage, so common in primary care, to send the appropriate patients to specialty genetic clinics. So I guess my question kind of around that comment is, should genetic counselors be working in primary care? Do we need to have, people in those positions? And, Jill's nodding. So since that's the case, how are we marketing ourselves, just like in the beginning of our field, you know, when the first classes of Sarah Lawrence and, you know, all of these programs started coming out, genetic counselors graduated and would pitch themselves to create jobs. That's how our field started. So looking back on our foundation, it's been over 50 years now, 52, 53, something like that, since we've had genetic counselors. What do we need to do and say to create positions in primary care? What is the pitch, Jill?
Well, you know, we have to show value. We have to show that there's something that we offer that can help, that will make life better for the providers we work with, and that will improve care for patients. And I strongly believe with all my heart that we do offer those things. And you know, having been practicing over the years and having been in, you know, in the earlier days where we did have to pitch ourselves, and a lot of the genetic counselors who graduated in my year back in the 1990s, you know, there weren't that many jobs available, and we really did have to create our opportunities. And I see that as an exciting space now for those who are interested in the primary care setting. There absolutely is a need, and we need to network. You know, if we think of our partners in industry, our industry partners don't set up their companies and then hope that people will notice the excellence of their services and come and use them. You know, that would be laughable. We know that for our industry partners, that they are constantly trying to educate people about the value that they can bring and what is unique about what they have to offer. And we need to do the same thing. We need to take that same approach. We have an enormous amount to offer, but I think that there's been some prominent studies that have been published in the literature, not to knock studies like Magenta. You know, it's an excellent study. It looked at what happens when you mainstream, you know, dividing people into different arms to receive pretest or not receive pretest counseling, and showing that lots of people who self-select for genetic testing will show up and go through and have genetic testing. And the measure that they used was a measure of, you know, psychiatric distress, that people are not more distressed after they go through this without pre or post-test counseling. And that, you know, genetic counseling optional. And it's just such an overstatement, I believe. Again, excellent study for what it showed. It doesn't show anything about what happens after someone goes through genetic testing. Do they have any idea about what just happened? Do they know the significance of the result? Do they know what it means for themselves? Is there any attention paid now on how to communicate this information with the family, and to encourage cascade testing? You know, we've known since the early days when Karen Lehrman was doing these studies in breast cancer patients that we're not creating psychiatric distress with genetic testing. It's not to say we're not making people anxious or worried, but there's a difference between that and true psychopathology. And so, you know, a lot of the studies that look at non-inferiority and focus only on psychiatric diagnoses as an outcome are not really getting to the source of, you know, what is it that we bring to the table. And I really want to reiterate Laura's idea that we need better outcome studies. We need outcome studies to show what is the value that genetic counselors bring to the table. And it has to go beyond just, we can get people on the conveyor belt to have genetic testing, because we know there's lots of different ways we can do that easily. We can get people testing, but then what happens? That's really the key, I think, in the value that we have to add.
I agree with this, and I would also add that firstly on the psychometric type of test and the well-being, I guess, outcome, that there are a few UK measures that we're using. I think Myron McAllister has published such a scale, but also from experience, I know that our greatest weapon probably is health economics. It's very difficult, of course, to measure, because in genetics, you have to study someone and their family for a decade or two to realize outcome. But what fascinated me the most while we're working to mainstream Lynch syndrome testing back in the day was that the benefit was only realized once you added in their relatives being offered screening, because that would have given us a reduction in cancer rates and perhaps at least an early diagnosis, which means better treatment, better outcomes. And at the same time, a Dutch group published a paper showing that the majority of families with BRCA1 or 2 and Lynch syndrome would not share their results with family members and may in fact share years after their diagnosis. So I would imagine that a relatively feasible way to measure a good genetic counselor intervention is by seeing and measuring whether patients know who to speak to after a diagnosis, how to speak to them, how to engage with their relatives, and seeing that that materializes, because that family element is the one niche that no one can actually do better than us. And the other one element that I wanted to mention to this in regards to primary health care, and Laura said something earlier that resonated deeply with me about ChatGPT, because I see so many individuals are trying to kind of like create chatbots that do genetic counseling and essentially avoid the human contact. I feel the human contact needs to be there, but maybe we could, as specialists in this field, advise and recommend what type of solutions we could have to perhaps gather family history, such as phenotypes, or educate our patients ahead of the appointment of what inheritance patterns we have and what the genetic test does and what is a VUS, so that at least when we meet them, we have the meaty conversation around how they feel, what their aims are, and how they will communicate with family.
I'm not as nervous about these chatbots and everything because I feel like a lot of the conversation around it is like, oh, it's so new and it's going to take over our jobs. We've been having this conversation for at least 10 years, I feel like. And that there's been these chatbots. Yes, are they much better now? Definitely. You know, I think with the advent of AI over the last 18 months, it's been great. And I utilize that a lot in my podcasting world and a little bit in my genetic counseling world. You know, you have to be very careful of HIPAA, but some institutions have their own version of ChatGPT where you can actually put in HIPAA information because it's part of their EHR and all of this. And that's awesome. But I'm not nervous about it taking over our jobs. As Dimitra's saying, I think we got to use this tool. If you're not starting to figure out how to integrate it into your workflow, you will get left behind. And that's just my personal view on that. And so I'm not as nervous about it. I'm more excited about how can we utilize this and make sure it's being utilized correctly. And so that, as Dimitra's saying too, that it's like we can have certain questions answered ahead of time and then be able to focus more on the discussion aspect and what do you want to do and playing out. Do you want this testing? What could this testing mean for you in that personalized conversation, and less of the conversation about this is what the genetic test is, blah, 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 right? We all have in the years we've done clinic, having our little spiel where we could do it in our sleep of what is this genetic test? What is a VUS? Like, let's take that part out. Like the stuff that I repeat 8 times a day when I see patients, I'm fine with taking that part out and just being like, hey, did you have any questions? Did the NIPS make sense to you? Like all of that. I think one aspect that is really big for me in terms of mainstreaming is this kind of primary care and also looking at preventative. I think that there's been so much more of a focus on that and being such a great thing. I think as our field evolves, we're able to do much more preventative work as opposed to treatment work. And that's a great direction we're headed in. And I think about, I don't know how many genes we're at now, the ACMG 81 are we at now, maybe, in terms of how many actionable genes that the American College of Medical Genetics, Genomics, I'm getting that right, has said, hey, these are ones that people should be aware of. I'm picturing a near future where in a primary care setting, people are offered that, hey, do you want to know about this list right now? I think we're 81, and then being able to do something about that and having that be mainstreamed. Have you guys thought about this in terms of having people offered this at a GP appointment, if that's appropriate? Do GPs know enough about this to be able to offer it? And then if something comes up, then refer?
It's a hard question,
It
Kira.
is.
You know,
Hence the pause, because everyone's like, I don't know. Why are you asking
I
me
mean, the
this?
primary care setting now, as everyone knows, it's there's so much that goes on in these appointments. They have very little time with each patient. And to add a conversation about the merits of let's sequence your genome, you can imagine would be very difficult. Now, again, not to say that there's no role for this in primary care, but I think it's medicine in general is challenging right now, and we are no different from every other specialty in trying to figure out how to integrate efficient, excellent care within the constraints of a system that's grown difficult, on a number of levels. So but yes, I can envision it. There's a study with Robert Greene at the Brigham with BabySeq and screening, newborn screening infants, and seeing what happens as you follow these children over time. So it's clearly something that's happening in the research field, and I think is going to find its way increasingly into, routine practice. And I think we need to leverage everything in all of it. And I think we can't say this is better than that. We should only do this and we shouldn't do that. We should look at all of the resources, all the chat GPTs, all of the ways we can increase personal interaction. All of it has to be utilized in different ways and combinations, depending on what our assets are, depending on what we have access to. All of it is going to be needed to deal with the complexity of how to deliver, excellent care given the healthcare system.
Yeah, I agree with that. I think it's very complex, and I don't know if GP appointments are long enough to be able to bring that up. But I don't know where the appropriate spot is in our healthcare systems in US, Canada, UK is where most people are listening from right now. It's like, where do we put that? Right? Like, because even a lot of people, I'm in my late 20s, like a lot of people my age may not see a GP. They might kind of treat their GYN as a GP if they're female. And so even that, it's like, that's pretty quick. So it's like, where do we put this in terms of, at what age? Like, obviously, if we're talking preventative, we do want to do that relatively early. So I think that's tough. And I see our Q&A is just popping off. So I want to get to at least one of these in the moment. There's a question. What are your thoughts about the ability of non-genetics providers to manage consent ordering for trio, exome, or genome testing? This person is asking and saying the GCs in our group have always taken responsibility for this as high complexity testing, but the volume is becoming unmanageable, which makes sense. I think a lot more people are ordering exome, and I'm thinking this is more in the peds space because I feel like if we're looking at trio, I think peds. Any thoughts on that of just being able to manage the growing demand for trio or quad? Sometimes there's a sibling to throw in there.
I think it'll make its way into the repro space, so you'll have a chance to look at it soon.
Yeah, I think so. I've already ordered some exomes for patients off of amnios, and I think that's going to be growing more and more. So maybe it will be less peds and more prenatal. So then I'll be complaining about this in 2 years.
Yeah. Can I just go back to what you were just talking about? I just think there's no one size fits all solution to this. Like, because I've done some studies where looking at introducing pharmacogenetics in the primary care setting. That's a pretty straight shot, right? Like the information needs to be a little better, but you can explain it to people. It can go into the medical record, what uses it has and so on. It's very different than getting back a Lynch syndrome result or getting back a BRCA result, in terms of what people need. Demetra's absolutely right when she's talking about like expanding the metrics we use to measure the success, to include things like cascade testing. That's great. It's just in other specialties, it's going to be something else. I mean, like the great work that Janine Austin up in Vancouver has done in psych genetics, looking at things like self-efficacy and adherence to treatment and other things like that, which in those specialties, maybe where to look, what is genetics doing for you here? I think if you're talking about giving people information that has to do with metabolic syndrome or, heart health or whatever, the metrics of what means success are going to be something different there. But the question is, are we given the funding and the tools to go beyond just giving out information, putting it into the medical record, and that. And genetic medicine will never be as good as it can be unless that is true. I as a genetic counselor bias, but I think like the other people on this call are going to agree with me, like that piece. And I love your optimism. I love your optimism, Kira. I've always loved your optimism.
It's not coming through today. Why am I being so negative today?
November 2024, right?
Yeah, that might be part of it.
It's really hard to feel it, okay? It's really hard to feel it. So go
I
ask.
think I think I have so many things that I want to happen. And as I say a lot on, on this DNA Today, a lot of the different recordings, that it's like, I want progress to move so much faster than is realistic. And sometimes I need to pause to be like, wow, we've come a long way, right? So I think that's important. Demetra, I think you were about to say something.
Yeah, I feel like we're playing a bit of a chase with technology. Technology is moving faster than a system has, or even the workforce has. For me, it feels weird that we're offering trios without the prerequisite of a connection with a genetic counselor and an MDT with the lab. Because by definition, these are way more complex tests. You have three people, exome, most likely will have implications for perhaps the next generation, whether the couple would like to have another child, etc. So
secondary
it
findings. I
feels
mean, you got to
like
cover that. It's a lot to cover.
absolutely, absolutely. For example, looking back and learning from history, which is something that Laura said, predicting history, I am certain that this is something that radiologists went through. I don't think 100 years ago people would have discussed an MRI scan with their doctor, right? The MRI scan became available, it complemented histopathology, and then you had this MDT structure where the radiologist, the histopathologist, the oncologist, and the surgeon were discussing things together. So I can't see why this is not happening here. It's similar. I think it's the same thing because you're adding complexity to complexity. So you just need to bring it all together.
Right. That it's just, and it's not like genetic testing is a new concept. We've had it for decades, right? And in certain areas, like Jill was talking about, we've added that in the cancer space. When did we start clinically offering like BRCA testing? Late 90s? Because we discovered the genes early 90s?
1996.
1996. Nice. All right. I'm going to try to lock that in my brain. So, this isn't new, right? That's like 30 years old almost. So it's being able to keep up with it. And I think a lot of what we've been talking about is, okay, yeah, predicting the past has become our phrase here, and learning from that, but then also looking at, okay, like how are we going to be doing this in the future? But let's give something concrete, hopefully. So we have someone asking, can you please elaborate on any experience any of the three of you have in which mainstreaming was successful? So either in your own experiences with patients, or Laura, more in your experience of hearing and interviewing people or writing about something. Is there something that comes to mind to be like, hey, here's an example of how mainstreaming has gone well, and maybe what we can use as a guide, because we need more of these research papers and stuff to say this is how useful we are and how great it is. Jill, you're nodding. Do you have something in mind?
Well, I can talk about our experience at Dana-Farber, which, I have been part of, developing over the years to try to increase access. You could call it mainstreaming in that we have our providers that we call GTCs, genetic testing coordinators. These are bachelor prepared individuals. They are classified in an administrative role, but they are at the forefront in clinic with our newly diagnosed cancer patients who are de facto genetic testing candidates just by nature of their diagnosis. We don't need any more information. And these are the folks who need quick access to testing because it could impact upfront care immediately. And this is an environment where we just have to increase access. And we have 29 genetic counselors at Dana-Farber. Even with a massive team like that, we cannot get to everyone. And so I think one of the strengths of our team, it's kind of mainstreaming in that you meet with a genetic testing coordinator, you will see a video that the whole genetics team had a hand in preparing, going through the information. And so patients thematically endorse, yes, I want this information, or they can say, this this video raised questions. Now I'm not comfortable with this. I feel like I need to meet with a genetic counselor. That's an option. Most people do not take up that option, but it's still available. And then there's a little bit of in between. The GTCs may be with a patient in clinic, and I call it the phone a friend option. They're literally there tapping out a message to us live on Teams, and we're able to address a relatively simple question that the patient has, or sometimes we'll get on the phone and quickly be able to answer someone's question and then move along. So for a lot of patients, their entire encounter will be with, a bachelor's prepared, trained individual, a GTC, who will arrange the genetic testing. It's going to be one, multi-gene panel. They're not trained to select one test versus another, so it's going to be a large panel. And then if everything's negative, the GTCs handle the entire process. There will be potentially no contact with a genetic counselor whatsoever. And so the oncologist is informed and so on. We scrutinize all the VUSs, and certain GTCs know how to go into ClinVar and they can see, are there any discordant results? If there's any discordance, it goes to a genetic counselor. So we don't just ignore the variants or just say it's a VUS, nothing more is needed. In a small number of cases, we have seen discordance and we manage those differently, because even though the ordering lab called it this, we ultimately agree that that classification is not what we're going to follow. And so I think that this sort of integration and kind of saving the genetic counselors for the back end, when there is a positive result, has worked well for our team. But all along the way, because the team is integrated, there's space for a little bit of, reaching out here or there. It's not a completely divorced team where the only way to have any contact with the genetic counselor is to schedule a separate appointment. And so
That's
we've been
so
very,
streamlined.
yes.
Wow. So just so I'm getting this right. So the genetic testing coordinators, I think that's the term you're using, that have that bachelor's degree. Also, side note, what a great job for people that want to go into genetic counseling. So check that out.
We turn over every couple of
Yeah,
years.
yeah, right. So,
Yes.
but with that, so are they also delivering negatives? If the panel came back completely negative, are they informing them genetic counselors are not getting involved unless there's a positive or a VUS that's kind of questionable?
Correct.
That's great. That's great. Laura, I think you were going to say something.
Yeah, and I think another example, well, actually, maybe Jill will comment on this, but so I remember going back to when I was doing training, and you'd have these models in some cases where they had disease-specific clinics, right? So the patients would go to the clinic day, and instead of having to, if they had a genetic condition, that I have to see half a dozen people, or one person's talking about testing and another person is talking about this type of treatment, that type of treatment. They go there and there's, the doctor and the genetic counselor, and if necessary, a social worker and other professionals all there on the same day to meet with that patient in true coordination of care. I think a lot of us saw that those sort of disease-specific clinics worked really well for the patient. I recently read that they're becoming more common for people who are BRCA positive, or maybe who have other breast cancer susceptibility genes, or maybe could do it generally cancer susceptibility genes. There's sort of one-stop shopping for them, so they can go to one centralized place to find out, are they a good candidate for surgery? What are the options in terms of surgery? What about what about chemo treatment? What about surveillance? What about, I know, Jill, you're going to do a better job than I am of doing all these whatabouts, but I thought what a great idea that is. Working around genetic susceptibilities, instead of having people, going in 6 different directions. Do you agree that I feel like I'm talking about cancer in front of Jill Stopfer, so that's
Well, yeah.
That's a
I mean,
choice,
I think
Laura. Yeah.
it's part of the then what happens, right? Again, it's the sort of the mainstream. There's so many different ways you can get people on that conveyor belt and get them testing, but the then what happens is really so crucial. And so, a great example of what we have is, these multidisciplinary clinics. The days where you meet with everyone on one. No, that's
But it
that's
works so well in peds, right? I hear of friends that work in peds and they're like, this is my Williams syndrome clinic day. Right. Like, and I'm like, that is so helpful for the parents.
I mean, it's
They just,
golden. If you can
yeah,
do that, it's golden. I think one of the things that we have going for us now is the ability to do remote visits where we can do video conferencing, and we can not require that everyone come in physically to a particular location to have a very detailed conversation. That's really opened things up. And in the darkest days of COVID, which were terrible, one of the things that happened is there was a relaxation of the who you can meet with. And so we have, for example, a very prominent Lynch syndrome center. And there were people who were scheduling video conference appointments from all over the country because there was, the licensing laws were relaxed for a period of time. And, now we're back to you have to be in the state of Massachusetts to do that. But, what a wonderful thing that was, to give access to some of the world experts on Lynch syndrome for those who benefited from it. But this idea of having, true experts quarterback, what needs to happen, or at least have access once someone has been tested wherever, have access to someone who can provide them with a plan for what to do. And since things are evolving so quickly, even in our specialty area, and I'm sure it's like this in other specialty areas, it's hard to keep up with. Do you screen for colon cancer for this or not? Check two has been flying back and forth. Yes, it is. No, it isn't. Now it's no, it isn't. It is difficult, and we see all the time. And again, I think this is probably universal depending on your practice setting, people who have done things that are irreversible, that didn't need to do them, or have been managed inappropriately because the recommendations that are being followed are outdated. And look, this is not unique to genetics. This is the challenge of, practicing medicine now, where globally information moves across very, very quickly. And so again, I think partnering with providers and being there for when our expertise is truly needed. And so the kind of saving things for the back end is the way we've landed on how to provide the expert care when it's truly needed. Although, not meeting with people ahead of time, is it better? I don't know. I mean, it's better if it increases access when it's needed. And the better part of Valor is we need this information for treatment, and we do it. If it were possible for people to have, more in-person conversation and dialogue with a human, would it be better? Yeah, I think it would be. Is it practical? No, I don't think it is. And so we have to come up with the best combination of, what are the key critical things we have to see in our practices, and then where can we make things better, along the way.
Dimitra, did you have something to add on to that?
No, I absolutely agree. I think I would also add that in our experience, we do have a few centers in the UK that have a very, very deep knowledge around genomic conditions like ophthalmology centers or cardiology centers. And to be honest, they deliver excellent care. They see the patient for their annual review, and they also discuss their genetic finding. They know their disease way better than I personally ever would. And I feel like that's excellent. However, if, for example, we're speaking about a patient with Li-Fraumeni, would I be happy for them to receive a result through the mail? No. And I'm not sure whether any one specialist would take responsibility in looking after those patients. So I think we have to make different categories.
Yeah, that becomes very challenging because everybody's going to have a different viewpoint on what goes in which category and what do we do with each category. So I mean, Laura, you always have this phrase, and I'm always trying to get the phrasing right, but genetics, it's a lot more complicated than we thought. And I think that applies to here too, in terms of mainstreaming. It's like, it's like, oh, well, we'll just mainstream. Like genomics should just be everywhere. But it's like, I mean, this conversation could be hours. I have so many more questions, and so do, the viewers and listeners. And I've got like a minute left. I'm like, oh my gosh.
That's what I say. If I ever wrote a textbook on genetics, which, by the way, will never happen.
No, don't do it. Textbook? No.
Genetics, it turned out to be more complicated than we thought. That's it. That's
yeah. That's encapsulates everything in genetics right there. I quote you all the time, Laura. I think that's the thing I quote the most in all of these talks and stuff, because it's just, It's so true. And every aspect of it, right? Even the how are we figuring this out in all these healthcare systems and even just in these different countries, right? And I'm kind of bummed we're already at time because as I said, you guys are all just like so well informed in all of this and just also asking so many interesting questions of like where we should go. And just like any good webinar, I've left with more questions than answers in terms of just thinking about how we approach this. And hopefully our viewers and listeners are kind of feeling the same way. But thank you so much, Demetra, Jill, and Laura, for taking an hour to talk about this. We're, predicting the past and where we're at and predicting the future. I think it's an area that's of great interest, and we're just going to see this develop a lot more. And I wonder just in the next year if we're just going to have more of that. And I'm personally intrigued of more genetic counselors that are going to be working in primary care. If you do work in primary care, reach out. I would love to be able to chat with you and just see how that experience is going for you, especially the people that are trying to start the SIG at NSGC. Best of luck. But anyway, so that is our program for today. Our social media is on here if you want to check us out, and make sure you go to phenotips.com, click the resources tab, and that speaker series is going to pop up on the drop-down menu. All of our installments are on there, and I'm a podcaster, so I have to plug that the show is also available as a podcast. So just type in PhenoTips Speaker Series into Spotify, Apple, wherever you absorb your podcasts. And our next webinar is going to be in the new year. So hopefully everybody enjoys the holiday season, and we are looking forward to coming at you live in 2025. I didn't even mean to rhyme, but hey, look at that. Thank you, everybody.